it's my utmost pleasure to introduce the next speaker today for the grand rounds is a friend of mine, Dr. Ross Upton, who is the CEO and founder of Ultramics, an AI company, which I'm pretty sure all of you have heard about in meetings and conferences. And they really build diagnostic algorithms. And I got to know them earlier on in my career. And I think it's wonderful. And they enable early and better detection of heart failure in echocardiography. Ross, during his time at Ultramics, I think has built a wonderful team, has achieved 4 FDA clearances, 2 FDA breakthrough designations, 2 reimbursement codes now for heart failure with preserved ejection fraction, which he'll talk to you about, 2 CE marks, and has raised more than $60 million in funding. He has a broad scientific background, has taken 4 degrees in clinical sciences, 2 masters in clinical biochemistry and cardiovascular imaging as well. He actually started off training as a physiologist within the NHS system in the UK before completing an PhD in cardiovascular medicine at the University of Oxford. He's really spearheaded the program of the heart failure program, the HeartShare, which is a huge program in the UK, really dedicated to identify phenotypes of heart failure with preserved ejection fraction, and also have served a couple of co-chairs as well in the AI steering committee in the field. And so it's my utmost pleasure today for Ross, Dr. Upton, to be speaking on applied AI in echocardiography. Thank you so much, Ross, for joining us today.
Thank you for that introduction, Nadira, and thank you, Minnesota Heart, for having me. Very much looking forward to giving this presentation on applied AI in echocardiography. So let me share my screen. Hoping you can all see that. So just to, well, Nadira did a wonderful job of introducing me, but I'm calling here from the UK. We're based in Oxford, so it's just gone lunchtime for us. So I appreciate everybody getting up early in Minnesota and coming to listen to me talk in cardiovascular rounds. This talk's going to be on applying artificial intelligence to echocardiography. And when I think about kind of the echocardiography pipeline from my view, I kind of break it up into these segments, and this isn't all-encompassing. Echocardiography exists outside of this, but this is kind of how we think of it. And so you have the hardware, and then the machines that take the ultrasound images that you can acquire ultrasound images with. So you've got broadly cart-based, handheld, and there's some machines in between now as well. And all the big players, Philips, GE, and the traditional players make the ultrasound carts, and coming through now, you've got some really neat handheld devices. Lots of you are probably aware and probably have a Butterfly or a Clarius or a GEV scan, so you're able to fit an ultrasound scanner in your pocket. And then moving on, you've got the guidance and quality piece where you've got AI companies working on helping you acquire images by helping guide you take the right images, helping guide you take the perfect 4-chamber, for example. A couple of companies that do this really well, like Caption Health and Ultrasight. Then you've got to store the images somewhere, and that's what we refer to as PAC systems. And then from an AI kind of pipeline point of view, and what I'm going to be focusing on today is you've got to sort these images in the storage. So you've got view classification, which view is an apical 4-chamber, which view is a 2-chamber, which view is a short axis. Then you've got, how do I measure these images? And that's where AI can help with auto measurements and providing kind of auto EF, auto strain, auto Doppler tracings. And then finally comes diagnostics. Can an AI actually directly diagnose a disease from the image? And these are the 3 buckets that I've worked across in my career, but that Ultramics is kind of that Ultramics focuses on with its products. this is the Ultromics product portfolio and roadmap. And so we started actually in the area of coronary artery disease. We then generated auto measurements for LV function. We then moved into HFpEF, and our latest product is focused on disease detection for amyloidosis. So let's start with our first application that we built, and that's called EchoGo Pro, which is our coronary artery disease diagnostic. I started working on this in 2014 at the University of Oxford, where I was doing stress echo clinics with my professor at the time, Paul Leeson, now co-founder of Ultromics. And we were seeing, a lot of patients come into stress echo clinic. We were eyeballing it, as you do, eyeballing the scans to see if they had coronary artery disease. Probably a few of you are familiar with putting your pen in the middle of the ultrasound screen in the middle of the left ventricle to see if the walls are collapsing in towards the pen. That was only kind of 10 years ago, but that's still being done today, just to get an idea, see if there's any regional wall motion abnormalities or anything like that. And so we thought back then, could there be a better way of doing this than just sticking your pen in the middle of the screen and trying to manually quantify regional wall motion abnormality? And so the goal was to try and improve the accuracy of coronary artery disease detection using AI. And back in 2014, it was a relatively emerging concept in medical imaging. And so we had to build a pipeline to try and detect coronary artery disease in stress echo. And this is kind of what the pipeline looks like. And kind of all of our products fit into this pipeline one way or another. But first, the first step in the pipeline is, how do you identify the right echo views for the pipeline? So with stress echo, we were interested in apical 4, apical 3, apical 2 chamber, and the short axis views. And so we had to teach an algorithm how to identify and pick out the right images. Then how do you contour and delineate the regional area of interest? And so in this case, it's the left ventricle that we were interested in. How do you then take the right cycle selection? How do you know which 4 chamber has the best heart cycle to take? Was there an arrhythmia in there? How do you differentiate that? And then finally, after that, you can output the quantification. And then finally, you can go to the disease detection after that. So all of these steps go into EchoGo Pro as a product. And this is roughly what it looks like. So these images and figures are taken from our JACC imaging paper. But we trained it on a database of about 578 patients, which actually doesn't seem like that many echoes back then. And certainly with brute force convolutional neural network approach, you would need many more patients to get an accurate classifier. But given that we took this approach, we were able to get away with doing it with less patients. So we went through the AI pipeline, we identified the views, apical 4, apical 2 chamber. We had to differentiate between contrast and non-contrast, so we had to have different models because stress echo, you get a bit of both. Then we had to auto contour these left ventricles, and then we fed it through, and we then put it into our feature generation engine, as we called it. And this was to try and pull out as many different features that we could from these contours. And we pulled out the regular features like ejection fraction, strain, volumes, and wall thickness, everything you would think of to try and detect coronary artery disease. But then we took a lot of more novel features that haven't necessarily been measured in echo. Some things like principal vectors, which was taken from continuum mechanics, and lots of other. We pulled out about 1,000, 2,000 features in the end from these the left ventricle contours, all of which we thought may give us an indication of whether a patient had coronary artery disease. We then selected the very best features according to our machine learning algorithms, and these are all kind of novel features. These are features that you've never even really heard of before, that's measured in echo, that had the best predictability in diagnosing coronary artery disease. And we tested it on an independent data set of 154 patients from the Rainier trial, which was conducted at OHSU. And we use an ensemble machine learning model, and that had SVC, random forest as an ensemble, and those were our results. So we were able to generate an OROC of 0.934 in the training data set, an OROC of 0.927 in the testing data set. So on fairly modest number of patients, we're able to get a model that generalized really well for predicting coronary artery disease in an independent data set across the pond. We then actually gave it to 4 cardiologists to read with the device and read without the device, and we did a crossover reader study design. And what we saw was that when the cardiologist used the device, they actually increased by 10% in sensitivity versus without, and 2% in specificity versus without. So I think it's one thing, building an accurate model, but it's another thing seeing how readers and cardiologists interact with the AI model, and the fact that we were able to build both an accurate model and improve the cardiology reader performance, I think was quite a good win for us. And finally, we've put this model forward as a prospective RCT across 20 different hospitals in the NHS. This reads out this year, so it's been trialing for a few years now, and we randomized clinicians to using the device and not using the device, and seeing what the outcome of the patient was over 6 months. So our primary objective was non-inferiority to the standard of care, and our secondary was superiority to the standard of care. And we were able to follow up every patient for 6 months, see if they had a coronary angiogram, and if they had significant stenosis on that coronary angiogram, and if they didn't, did they have an event caused by an acute coronary syndrome. And the results of this read out, they've read out, we're analyzing them at the moment. So it's going to be interesting. We expect this to be published this year. And yeah, it was quite a large study, 20 NHS hospitals and 2,300 patients. And yeah, I think it's going to be the first prospective AI RCT of its kind, certainly in this space. We then went on to develop a product called EchoGo Core after Pro. And this is a automated measurements-based product. So it outputs things like automated ejection fraction, volumes, global longitudinal strain. And this uses just this part of the pipeline. So everything up until disease detection. So we still have to identify the views. In this case, the 4, 3, and 2 chamber are really important. We still have to contour the ventricle, and so it runs through our auto contouring engine. We still have to pull out the right frame for analysis. This is particularly important when patients have arrhythmias. And then finally, we're able to produce the measurements on the report. This was published in JACE. We published our humans versus AI echo analysis as a predictor of outcomes. This happened during COVID. So it was a time where you could get quite immediate outcomes following the echocardiogram of patients. And what we found was just by removing the variability caused by manual measurements, that it actually helped predict outcomes in patients. So the AI, but not the manual LV analysis, were predictive of mortality in patients with COVID-19. And that was just by taking out the interoperator variability and using AI to automate decisions like view selection, where the contour goes, the right frame to select, because all the variability that you introduce manually when you do this is obviously huge, and that made it significant when it came to patient outcomes. Moving on to EchoGo heart failure. This is our new product and our flagship product. This is a disease detection algorithm that predicts HFpEF. It gives you a binary. This is suggestive of HFpEF, or this is not suggestive of HFpEF, but also it provides a probability from 0 to 1, which you can see on the right-hand side here. As far as this goes for the AI pipeline, we actually skip out a good chunk of this. So this is disease detection directly from the image. So we still use a view classification. This model works by feeding an apical 4-chamber in, and then it's a 3D convolutional neural network that works directly on the image. And so you don't need the contour, you don't need the cycle extraction, and you don't need the quantification, because it averages across the view works. The classifier works by working across the cardiac cycle. It doesn't have to select a particular cycle, and it works directly off a pixel level, so it doesn't have to have any features that feed into the classifier or anything. This is a 3D neural network, so we're able to skip over a lot of these steps. So the benefits of doing that is, with large amounts of data, you can probably get to a more accurate disease detection by doing that. The downsides are you get less explainable AI. So EchoGo Pro is quite explainable because we know every single feature that goes into EchoGo Pro, and although it is a classifier that makes a decision in the end, we're able to see how the features are used within EchoGo Pro. With EchoGo heart failure, this is a 3D neural network that works directly on the pixels itself, so there's no features that go into it per se, and it's less explainable, but uses a lot more data and is really quite accurate. So why did we make the decision to generate a HFpEF classifier? Well, HFpEF, as I'm sure you all know, constitutes about 50% of all heart failure, probably greater than 50% of all heart failure now. But one of the big things is that it's projected to cost near $70 billion in hospitalizations by 2030, which is obviously a huge amount of money, and that's heart failure in general, but HFpEF constitutes a major chunk of that. And simultaneously, the FNIH announced it as the biggest unmet need in cardiovascular medicine. That is, that it's causing all of these hospitalizations, and there's very little treatment, and it's very difficult to diagnose, which is a double whammy for helping tackle the disease. So they initiated a $37 million project, a 5-year initiative, to try and help with the HFpEF phenotype and classification, and try and enable more treatments for this. And we joined this initiative along with others, and I now co-chair the AI committee of this important program. That said, we did have our first breakthrough in HFpEF therapy fairly recently. this was published in the New England Journal of Medicine, where this SGLT2I inhibitor reduced the risk of heart failure hospitalizations by anywhere up to kind of 30%, and that was empagliflozin. And then we had a follow-up study, the DELIVER trial with the dapagliflozin, and that showed a lower risk of hospitalization by 24%. So for the first time ever, two big therapies came through 2021, showing a relative risk reduction in heart failure hospitalizations for patients with HFpEF. And there was a nice analysis in JAMA Cardiology saying, just over 250,000 events could be prevented by this medication. It's not just SGLT2Is that are coming through with the NIH trial and a lot of other companies working in this area. We've got many more therapies coming through. There's the first potential medical devices for HFpEF therapy coming through. Two of the companies that are making the shunt devices are Alleviant and Corvia. These are shunts that go in the interatrial septum, and they're designed to shift pressure from the left side of the heart to the right side of the heart, alleviating HFpEF and alleviating the symptoms. So very soon we could have a medical device for HFpEF. There's other things being looked into, like splanchnic nerve ablation and a few other medical devices coming through. There's other companies trialing myosin inhibitors in HFpEF as well, which I think could be very promising too. So there's lots of focus in trying to bring through therapies that reduce heart failure hospitalizations in HFpEF. But what is still difficult is actually diagnosing HFpEF, and actually many of the companies and many of the trials I've just mentioned, one of the biggest difficulties is actually finding the patients to go into those trials. Often we don't find HFpEF until it's far too late, until they've been hospitalized. And so finding HFpEF is still a big problem, which is why we decided to build a device in this area. So from a single 4-chamber, we created a 3D neural network model that is able to diagnose or detect HFpEF with greater than 90% accuracy, and able to have a sensitivity of 88% and a specificity of 82%. And we designed it off of, we developed this with the Mayo Clinic, and we designed it off a 4-chamber specifically because we felt like if you could do it just off a 4-chamber, it would give it broad applicability. It could be used in kind of community settings. It could be used with POCUS devices. And so the idea was we tried to use as few views as possible to try and get to an accurate diagnosis of HFpEF. This was our clinical trial data published in JACC Advances. We were able to achieve an OROC of 0.97, 0.95 and 0.91 on the training, validation and testing data respectively. That corresponded to an 88% sensitivity and 82% specificity in our independent testing data set. We tested it in 1,284 patients across 8 different hospital sites within the Mayo Clinic health system. The labeling we used to kind of designate whether a patient had HFpEF or not was they had to have a preserved EF. We used a cutoff of greater than 50%, although I think arguments could be made for greater than 40%. We used greater than 50. There had to be signs of structural heart disease and elevated filling pressures via the echo. And then finally, they had to have a clinical diagnosis of heart failure. We also had 5-year outcomes on all these patients as well to validate the models against. We compared our HFpEF algorithm to the H2FpEF and the HFA score across the 1,284 patients, and we saw that the HFA and the H2 score yielded quite a good chunk of indeterminate results. And so about 60% of the time, these two clinical risk scores were indeterminate for HFpEF. And you can see that on the left-hand side of that alluvial plot. And then on the right-hand side, you can see how EchoGo was able to rebucket these into diagnostic positive and diagnostic negative results. And in comparison, we only yielded a non-diagnostic result in 7% of cases. We looked at how we performed against the 5-year outcomes, and if we classed as diagnostic positive HFpEF, they had a 90% higher probability of dying over the 5 years. So it shows that our, where we're calling positive versus negative has a direct impact and direct kind of association with patient outcomes. This is, we kind of repeated a study with Harvard just to have a completely independent population, see how we performed. And this was in about 400 patients, 212 HFpEF, 226 controls. And quite astonishingly, to the decimal point, the H2FpEF score yielded 60.4% non-diagnostic again, exactly the same as in the 8 hospitals from the Mayo Health system. So yeah, it's mind-boggling that they both achieved exactly the same indeterminates to a point. And again, very similar story. We were able to correctly rebucket these non-diagnostics or indeterminate results into diagnostic positive and diagnostic negative. Interestingly, with these ones, we had the 1-year heart failure hospitalization data on these patients, and we were able to identify 78.9% of patients that were hospitalized within 1 year. We called positive HFpEF, and the H2FpEF score only was able to find 54% of patients that were hospitalized within 1 year. So yeah, not only were we superior in rebucketing the diagnostics, we were superior on 5-year outcomes, we were also superior at identifying the patients that would have been hospitalized for heart failure, which is really important for the therapies that are available, because those therapies are designed to impact the heart failure hospitalizations. Next, we've generated a product called EchoGo Amyloidosis. This isn't yet FDA cleared, but it received an FDA breakthrough and went through the FDA TAP program. Again, it looks pretty much exactly the same as HFpEF as a product. That's what the class probability looks like on the report. It outputs goes from 0 to 1 or 1 to 100. Again, we're working directly with the view classification. We're finding the 4-chamber and going straight to the disease detection, bypassing all the other pieces in our AI pipeline. Again, for the same reason that we did for HFpEF, we did that because we wanted to be really scalable. I think amyloidosis has got a similar story to HFpEF in the fact that it's very underdiagnosed. And I think the stat is that there's patients average 5 echoes before they're diagnosed with cardiac amyloidosis. And so we wanted to build a classifier to see if we could detect it earlier. We also wanted to make it scalable again, because we think that a lot of cardiac amyloidosis out in the community is probably not being picked up. So that's why we designed it off a 4-chamber view. And this work was funded by Janssen and Pfizer. And we got into the FDA TAP program for this, which is a new FDA program designed to be a more kind of collaborative FDA approach. So hopefully we'll have this one cleared, FDA cleared this year, hopefully halfway through the year. This was our ASE abstract. We haven't published a paper for amyloidosis yet, but we did an ASE abstract with a reader study, again, showing benefits that readers using the device increase their reading accuracy versus without the device. Yeah, last thing to mention about amyloidosis, the reason we generated amyloidosis, as well as it being generated an amyloidosis diagnostic, as well as it being an underdiagnosed disease, is as my colleague Sanjeev Shah would say, it's sort of like a masquerader of HFpEF. We think one of the reasons why a lot of the HFpEF trials have failed is because many of them had undiagnosed amyloidosis. They can often present the same phenotypically or similarly phenotypically. So we thought that if we're giving a HFpEF diagnostic, it's also really important to differentiate out those who have amyloidosis with it, because obviously there's very differing therapies for amyloid patients versus HFpEF patients. So thinking through how we deploy this, so we've trained all these models, developed all these products, and cleared them. How do we deploy them so clinicians can use them? We've developed a software as a service cloud-based system. So what happens is when you do your echo and the images get stored in your PACS, we have a secure VPN connection that pulls the images up into our cloud. We can anonymize the data there and then run them through that AI pipeline set of modules that you saw, and then send back a report through the VPN back into your PACS system. And so it's there for you to view when alongside the images when you're doing the echo report. And we say, 30 minutes turnaround time. It can be faster than that, often is within 15 minutes, but we say 30 minutes to give ourselves some buffer. And then we're able to give you kind of feedback and on a weekly basis through our service analytics in terms of how good was the image quality that we got sent, what was the average turnaround time, and all of that sort of stuff. So that's how we deploy it in clinic. Now, Nadira mentioned that we have some new reimbursement codes. These are very, very recent from CMS. These came in at the end of last year and one at the start of this year. So we got the NTAP code for the inpatients. That comes to about $1,000 as an add-on to the DRG code. So if you have a patient coming in that is related to a heart failure stay, is related to kind of one of those DRG groups, and you want to assess whether they have HFpEF, you can add our ICD-10 code, and then the maximum reimbursement you can get via the NTAP payment for that is $1,000 per analysis, and that's through Medicare inpatients. And then we've got our HCPCS code for outpatients, and that code is C9786. And this is a add-on code to an echocardiogram for outpatients, and that's $284.88 per analysis. And this is covered by Medicare, and there are some commercial payers that will cover it too. And so I think these are the first kind of reimbursement codes in this sort of echo space that are, that you can separately get payment for. I think previously the only one that was available was strain as an add-on measurement. But now we've got two codes that are in this kind of echo diagnostics bucket, which is good for, and will hopefully give more people access to our technology. And so that's kind of our modules and what we've been through to date and what we've developed. So we as a reminder, we had the coronary artery disease diagnostic first, the stress echo, the auto measurements, the HFpEF diagnostic, and now the amyloidosis diagnostic. In terms of what's next on the roadmap for us, we think hypertrophic cardiac myopathy, we're starting to develop that now, as well as hospitalization risk scores, heart failure hospitalization risk scores. And the reason we're developing these, I think, firstly, HCM, another masquerader of HFpEF, can often cause HFpEF, presents with kind of the thickened heart phenotype, and now has medication available. So I think it's important to be able to differentiate out when you're looking at HFpEF that you're not actually trying to treat an amyloidosis heart, or you're not actually trying to treat an HCM heart, because these are two obviously very different diseases in terms of how they progress and what treatments they have. So that's why we're trying to operate in that intersection of HFpEF and its phenotypes or its masqueraders. And the hospitalization risk score we hope to develop within a couple of years will give the idea is we're designing it that will give a probability of kind of a patient's 90-day, 1-year hospitalization risk. And so you'll be able to, you can take that into consideration when you're treating the patient, or when you're discharging a patient, you can see that individual hospitalization risk. And lastly, my voice is going because I haven't long had COVID I'm recovering from, so I think I'll stop after this slide, otherwise I may lose my voice. I've got through a whole AI talk without mentioning ChatGPT or generative AI, so I want to talk a little bit about what we're doing from a generative research point of view. So I think when people think of generative AI, a lot of people immediately jump to ChatGPT as kind of the application of generative AI, but there are many different applications of generative AI. And I think stuff that we're working on is in image-based generative AI. And one of the papers that our team have just published, I can't take too much credit for this one, but our AI engineers have just done an incredible paper on a generative model called denoising diffusion probabilistic models. And what they are able to do with this is generate synthetic echo images by using this generative AI approach, and then train a neural network to contour the synthetic images and then validate it on real echo images. And they were able to produce some remarkably accurate results in doing so. So if you can think about the implications of something like this, is they didn't actually need any training data to train an AI contour images, which I think could be quite profound and could be used in many different ways. And so that's just one of the few generative AI models that we're building internally, but I thought it is quite a good application of generative AI. Yeah, and lastly, maybe I'll just finish on that visual because it captures nicely kind of what we've been talking about today. So I'll stop there. Thank you.
Thank you very much, Ross, for the wonderful talk on the applied AI in echocardiography. I certainly learned a lot, the application of it, just listening to this and what Ultravox does. I think in the heart failure space and obviously the amyloidosis space. I think we have a question from John online. He's asking if how often does poor image quality that you see in clinical practice, the effect and disqualify an echo for analysis using this program of yours? And the second part to the question is, what's your experience in terms of the centers in the US or in the world where it's using this clinical program of yours on a routine clinical service?
Yeah, great questions. So image quality, it's always the biggie with AI, and it's why echocardiography largely was got the attention last of AI engineers. I think everyone flocked to MRI and CT because it had a lot better image quality, a lot better resolution, easier to train with. And if I'm being honest, I tried to do the same when I was a PhD student. I said to my supervisor, I can't be bothered with those noisy echo images. I'm going to go and do MRI and CT. However, his advice was, well, everyone's going to do that. If you stay in echo, you'll be one of the only ones at the moment. And if you figure out how to handle noisy echo images, it'll be, a much more impressive feat. And that was actually one of the best bits of advice I've ever gotten. And so coming back to your question, in terms of kind of rejection rates through the service, we've got about 7% rejection rate out of 230,000 scans that we've processed so far, and from kind of everyday clinics. So the way we handle that is our AI devices do output a positive and a negative result, and a probability, but we also have inbuilt into the model an uncertainty and instability metric. And so if the model deems the image as too unstable, usually maybe due to a probe, ultrasound probe moving through time during the acquisition, or the diagnosis to be uncertain, usually due to image quality, will output a result saying the AI is uncertain. And that happens about 7% of the time out of the 230,000 or so images that we've processed.
Anyone has questions in person, I have the audience microphones on, so go ahead and ask.
Okay. This is a fantastic talk. Two areas I'm interested in. Number one, have you used this on right ventricular function, for example, in pulmonary arterial hypertension patients? And second, have you considered using this as a non-invasive tool to identify heart transplant rejection?
Very good questions. The first is we haven't got a right ventricular quantification package, only left ventricular. For our heart failure module, we had pulmonary hypertension patients and right heart failure patients in both cases and controls, depending on whether they pass the threshold of being considered HFpEF or not. And have we considered it for use in transplant rejections? Yes, very recently. We are designing a research project with another institute at the moment to look at that question specifically. They were very interested in seeing if the heart failure probability could be useful in that, as opposed to or in conjunction with measuring diastolic function. So I think that's a very interesting area that we're looking to explore, actually.
All right, does anyone else have any questions? I think we answered the online questions. Anything else in person? All right, well, thank you so much, Dr. Upton, for your time and expertise. We really appreciate it. Is there any final words that you'd like to say to our audience before we let you go?
No, thank you for bearing through my sore throat, and really appreciate you guys listening to me rabbit on for 45 minutes or so. Enjoy the day.
Thank you so much.
Thanks all.